Monash, Professor Bain has pioneered advancements in data usability and EMR systems, gaining national and international recognition. Today, he'll share his insights on what in digital health is free, a profound topic exploring the true costs and value of technology in healthcare. Let's give a warm welcome to Professor Chris Bain.
Yeah, so I was already standing between you all and lunch. I'll try and impart what we have to impart, but still get you out for lunch in time. So as this introducer just sort of said, just a little bit of context for me. My background's in medicine, and then I retrained in IT. I spent about 27 years in the health system in our state, and then 7 years ago moved to the university as what's called a practice professor in digital health. So in our faculty, we cover an enormous range of things, the only faculty of IT in the country. But I spend a lot of my time working with other faculties and with doctors and hospitals and industries and trying to facilitate opportunities for our students. So what I'm going to talk today is quite selective, quite deliberately. We won't really go much into AI, even though AI is really important in healthcare. And there's a lot of work we would call digital health work happening using AI, but we'll steer away from that a little bit. You've already had a good swathe of AI things today. Just to give me a sense, hands up if anybody is currently working in health IT, health-related IT things. Not one hand. That's a bit of a worry. Okay, well, a couple. Okay. Anybody done it in the past? Anybody worked on health-related IT in the past? Okay, that's helpful because I need to know how much health to give you and how much IT to give you. I need to explain things appropriately for you. So we're going to start by talking about interoperability. So interoperability is this idea of how do we share micro-level information, in our case about patients. For instance, my blood pressure reading yesterday at 2 o'clock. How do I share that between systems, even within a hospital, let alone to the sister hospital down the road, let alone across the country, let alone across the world? And this has been one of the huge challenges in digital health. And just to set the scene a little more for you today, when I'm talking today about digital health, we're talking about everything from electronic medical record systems that are in family physicians' offices or hospitals, right up to some really cutting-edge systems today. I'm not going to dwell on any of those, but things like Cardia, K-A-R-D-I-A, where you can have an ECG, a cardiograph recorded on your phone, okay? So all of these things are happening at once and they are all digital health. But interoperability is a pervasive problem. For many decades now, if we look inside a hospital and we look at the laboratory system and the electronic medical record system that the doctors use, those systems share messaging, okay? And the nature of the messaging has been what's called HL7 messaging, HL7 version 2 in particular. It's what you're seeing up there. And many of you will recognise that's very computer readable, but not really human readable, okay? So if you have a close look, you can see there's an address in there. There's a patient who's called Eve, every woman. You can see that they're having a glucose test. You can see who the primary doctor is, Patricia, Dr. Patricia. You can see that the glucose test value is 182 and the normal range is 70 to 105. Okay. This is just to give you a bit of context. Then we moved on to the next generation of these messages. And these are called HL7 version 3 messages, so they're XML format. The same sort of content, but this time in XML, a little more readable. Okay. Nonetheless, we found that that didn't help enormously. There are a few reasons why it didn't help. We then moved on to an additional supportive thing called clinical document architecture, which is again XML. If you think of the referral letter that a GP, family physician, might write on the computer to send to the hospital, or you think of the discharge summary at the end of the hospital admission that goes back to the family doctor, those things can be electronically created and expressed as these clinical documents, hence the clinical document architecture, XML documents, but they can be shipped around, electronic payload, if you like. Now, the trouble with all that was it never really got far beyond working within a hospital, essentially. There's a few reasons for that. And so we continue to have this problem with how do we truly share information? How does information electronically, quickly and seamlessly and safely flow around to follow the patient? So you don't turn up somewhere and there's nothing there. They have to say, send me the fax or send me an email or send it with a courier pigeon or whatever it may be. And that's where this new paradigm came in. So this is free. All of these things I'm talking about today are free in the theme of ICTer. So in the theme of if you're in an emerging region and you want to do R&D work in digital health, these are various things that exist around the world that you can draw on. Okay. So FHIR stands for Fast Healthcare Interoperability Resources. And it is basically JSON applied to healthcare. So if you're familiar with JSON, you can figure out FHIR, and that's not accidental. So the idea was that we could import programmers in for other industries because they might have worked with JSON and APIs and web type information systems. And because it's JSON, they can quickly learn the medical content rather than having to learn that very bespoke HL7 version 2. Okay. And there's a whole framework around this. There's a lot of thought around it. It's existed for 10 years. But what it's actually starting to do is allow that sharing of information in a very real sense because it's native to the internet. So it allows me literally to share information about me now across the other side of the world if we wish to. Okay. Security, permissions, another thing. Okay. What you're seeing there is a diagram of just how well evolved this is and how well thought out this is. It's all now under the auspices of that broader HL7 international organisation. I'd be very surprised if there isn't some kind of representative group in Sri Lanka involved in HL7. But you can see all the domains there it's touching on. Each one of those things you're looking at, an allergy, a problem, a procedure, they are all individual resources, fast healthcare interoperability resources. And then if we drill down, the N stands for normative. The higher the number, the more evolved the standard is. Obviously, it's something at 3 is more evolved than at 0. But anyone who's worked in healthcare will look at all those things and go, wow, that's an awful lot of detail about how we model the healthcare information universe. Okay. So you can build systems off these. You can build interfaces off these. You can ensure that anything you build in health IT will talk to something else. Still, it's not magic, as you know. It's still difficult, but it's infinitely easier than it's ever been before. So why is this important? Well, we often look to the US. The US has a terrible healthcare system, but it's spent a lot of money on health IT over a long period of time. And if we go back about 7 years, there was a survey they did. And at that stage, they had 1,800, which was about 30% of the survey, hospitals at what is called level 6 MRAM, which basically means they're almost fully automated, almost fully paperless, so highly evolved hospitals, and many more at level 7. But effectively what we had was electronic silos. So if you went to 3 different hospitals, they couldn't share your information even though they were internally very evolved. They were basically no better than paper. And we know that in healthcare, when the information doesn't flow, that's when we have problems. When the next person involved in care doesn't get the right information, people can and do literally die. No one ever dies if they hack your information. No one, right? So that's the balance we have here, okay? So the key takeaway here is this is an open standard. You can build systems of it. There is no cost to doing that. It's not accidental that those big vendor names down the bottom have supported this. because that, from their point of view, if they support this, it's almost like starting to have a vacuum cleaner to hoover up everyone's healthcare data. So that is the downside, but it just shows the level of support for this paradigm. Just to show you in a bit more practical terms what it looks like, this is a instance we have of a Happy Fire server. Happy is just one instantiation of a fire server to host fire data. You can see all the different kinds here. It's just dummy data, but observations, encounters, immunisation records and whatnot. And we've used this to do some prototyping work. So that's one way that we can use the data, and this is sort of underpins that RESTful API type construct. You can send it around as individual messages, like I showed you before, and you can build up blocks of it into documents like we did with CDA. The creation of FIRE, this wonderful free resource for you, has enabled another series of technical developments, and one of them is Smart on Fire, which I'll come back to in a minute. So, people are often amazed when they look inside healthcare, especially when they look inside it with an engineering or a IT lens, at just how disorganised or inconsistent it is. That's not talking about the safety of the care and the quality of the care. It's talking about the fact that we've grown up on paper, and a lot of our systems are not explicitly designed, they have evolved. Okay. So one key area is clinical terminology. And again, there is a lot of free resources about clinical terminology. So has anybody heard of SNOMED? This very famous worldwide thing? Nope, okay. So I'll explain what these are and why they're important. Again, free. You can look up on the web, you will find SNOMED browsers, you will find Loink browsers. So the history in healthcare has been, if I let 10 doctors in a room individually decide how they will record the smoking status of a patient, they will probably come up with between 5 and 8 different ways. Because nobody ever taught them this is the exact way, and they never agreed on it. Okay. That might be fine in paper, but obviously when we move to electronic, that just makes a huge mess very quickly. So that's what SNOMED is about. Okay. SNOMED, Systematised Nomenclature of Medicine, a subset CT, clinical terminology, and I'll give you a fully blown example in a minute. So the importance here is if you are building these systems, again, for free of charge, you can go to SNOMED and you can say, okay, well, whenever we record the blood pressure of a patient, we're going to have at the back end this SNOMED code. Whenever we record the fact that somebody smoked, at the back end, we're going to have this SNOMED code. And there are probably hundreds of thousands, if not millions of SNOMED codes. But this middle point is really important, okay? Enables consistent representation of clinical content in electronic health records. And that gets even more important if I, from here, what patient in this place, go to be a patient in this place. You want them recording information about me in the same way, okay? It's very easy, it very quickly turns to mush if we don't have these kinds of tool sets and additive value mechanisms involved. So here's an example. So we have a condition in medicine called a myocardial infarction. It's anecdotally known in many places as a heart attack, okay? When people say they have a heart attack, they're talking about the death of a bit of heart muscle. So myocardium is heart muscle, infarction is death of heart muscle in this case, okay? And what SNOMED says is, I don't care whether you use any of those terms, they are all going to map to this code, okay? And there's a whole library, and that's why you need a browser to go through. But it also says a formal name we'd like to use is myocardial infarction as a disorder, as opposed to, say, a symptom or a treatment or this kind of thing. And it says, though, that all of those things are synonyms. We acknowledge all of those things are equal. Okay, so in theory, if you had a drop-down list, you could have any of those things, but you would map it to this single code, okay? But all of this is free of charge, okay? Sometimes when you're working with the big commercial players, the way they bundle this up, they'll charge you for.
But at its core, you can use this stuff and access it and build your own term sets out of it. Okay. LOINC is a little different. So one of the additional challenges of the healthcare world is we have clinical terms, we have drug terms, we have procedure names, we have test names, we have nursing terminology different to medical terminology. LOINC operates or has historically in the test space, okay, although it does other things. So a really good example is a test called a full blood examination or a full blood count that some of you may have had, very common around the world. I think sometimes in the US they call it a CBC, a complete blood count. And it's a composite. So it's a test. In the old days I would write FBE on the piece of paper, but I know and the lab knows and the nurse knows that's actually about 8 tests. Okay, so when we move to computer land, LOINC lets us keep that relationship, gives us a code for the high level test, and then also knows that that's inherently linked to a series of child tests. Okay, so again, if you don't use this stuff and you're building information systems in healthcare, very messy, very quickly, again, free of charge. Okay, and this is bringing a couple of things together. So sorry for those of you who aren't coders, it's not hard to follow. So this is an observation resource in the FHIR paradigm. It's quite a generic kind of resource. And it's actually, so it's JSON, and it's actually showing you how some of this might hang together. And in this case, it's a vital sign, so blood pressure, heart rate, temperature, these are vital signs. And specifically, it's what's called a blood pressure systolic and diastolic. So you've all seen on the television 120 over 80, 140 over 90. That's systolic, diastolic. Okay. So there's a LOINC code for that. But it also knows, LOINC knows, that that's made up of 2 things. It's made up of a systolic blood pressure, and so there's a separate LOINC code and a value, in this case, of 125. And it's also got a diastolic blood pressure with another LOINC code. In that case, it's 75. So that's the computational code in FHIR to capture the fact that somebody had a blood pressure recording of 125 over 75. So it's human readable and machine readable. And it's in a standard internet compatible way with JSON. Okay. All free of charge. No cost to doing any of that. So I'm going to talk a little bit now about different sources of healthcare data. We were in some conversations this week where people, quite rightly, computational people all around the world say this, can't build my models without data, and of course that's true. Okay. And this isn't a talk about data access in healthcare, that's got all its own problems. But this is showing you there are some examples out there, okay? Some well-known examples, probably more out there than you would think. And for any of you working in this space, I would encourage you to work with the data you can to start the process, okay? The people holding healthcare data are much more likely to work with you and provide you healthcare data in an R&D sense, real healthcare data, if they can see some merit in what you're doing. So if you talk in hypotheticals to them, they're often very concrete people. Doesn't mean much. If you go to them and say, here's some data we've got from the internet that looks a bit like this, it's consistent with what we want to do. Look at the model we produced, and here's the benefit of what we did. Now we would like to work with you with real health data. That's the way to do it. Otherwise, you'll just have a Mexican standoff. Okay. So these are just a couple of to-hand examples. There are many more. So we have a state cancer registry in Victoria, where I'm from, and they, for probably 15 years now, have had an online data browser. Now, this isn't accessible in terms of you will not get individually identified records, but you can get summative records and you can get potentially de-identified individual records. So you know that there's, a 50-year-old woman who had a breast cancer diagnosed here at this stage, lives in this location, okay? But that lets you download off that. So that's an example of cancer data. Here's just
what you see when you Google open source healthcare data. So there's a lot of data available. There's a whole site which looks like it's US government where it's available. There are 3,436 data sets. Now, we still have to be cautious of what we're seeing there, not build things beyond the scope of the data, not build things beyond the trust level we have with the data, but plenty you can do. I'm going to be a little more precise and specific. Has anyone heard of Mimic? In the audience? Okay, so Mimic is a particular kind of data and is very famous all around the world. And it's intensive care unit data. Okay. So that tends to be quite different from data from the rest of a hospital, for instance, and it's certainly different from data from the community. Often very detailed, often got a lot of drugs in it, often taken every hour, this kind of thing. Mimic is a collaborative out of the States. It's got data sources from 2 ICU units, 1 adult, 1 children, and it is freely available, okay? They've gone to a lot of resource and effort about de-identification, for instance, of certainly names, staff and patients, but also of dates, so you can't actually tell when, you know the patient was admitted for 5 days, but you don't know exactly when they were admitted or discharged. And there's myriad papers in the academic literature on the medical side looking at machine learning, for instance, using Mimic data. Okay, so it's a really good public resource if you're interested in that space. Cynthia is another one. Anyone heard of Cynthia? Again, American, not accidental, just because the Americans have had more of this electronic health data than other places for much longer. So they've been able to get to the next question and the next question much more than anyone else. So Cynthia is based on the population of Massachusetts. And you can access it from a command line. You can install a package and do things on the command line. Or you can call it by APIs. And it can give you data in a whole range of formats like CSV and Excel, but the reason I've used it is it can give you FHIR data. So if I want to make a mock SQL database of realistic looking healthcare data tomorrow, that's easy. Make a CSV file, duplicate, chop and change it, stick it in a database, okay, import it through a tool into a database. FHIR data is much harder because of its nature, because of its JSON structure. And Cynthia lets you produce FHIR data. And that's been very valuable to those of us working to it. But again, completely free, no cost. And you can do things like manipulate which diseases you want to look at, manipulate genders if you want to, just show me all the female records, whatever you like. It's quite flexible, quite interesting. I'm going to touch a little bit about free constructs, free architectural constructs, and we'll revisit this FHIR conversation in a minute. So some of this may feel a little far off for Sri Lanka, but the problems it's trying to address will come. So what they found in the States and other places, and we now see it in Australia, is a lot of the big electronic medical record systems, and they go by names, like Oracle has one now. It bought up a company called Cerner, Epic, InterSystems. They're spread throughout the Northern Hemisphere, States, Europe, also in Australia, Asia. And there's more and more places use these electronic medical record systems and work in hospitals that are increasingly paperless and highly automated. A universal truth has become clear, and that is many doctors and nurses do not like using these systems. Do not, okay? And there's a few reasons for that, and there's a lot of complexity underpinning it, but I won't get into that today. But what you're seeing here is an attempt to help with that. So I'll give you a simple example. If we have a vanilla, albeit highly complex, deeply rolled out system, if I'm a psychiatrist, you would all recognise that how I might need to use that system, when I might need to use it, what features I might need to use, is likely to be highly different from if I'm a neurosurgeon. And we repeat that problem for every kind of different hospital specialists. And all the while, specialists are getting more specialised. So if you're an orthopaedic surgeon now, you're not just an orthopaedic surgeon, you're a hip guy or a knee guy or a shoulder guy. That's the level of specialisation. So it's a bit naive to think that you'll all be able to use the same computer system, even though that's how we build computer systems. This is an attempt to allow independently developed EMR modules, software modules, to be built by third parties but deployed inside these complicated EMR systems, like putting them into SAP, for instance. That's the level of complexity of system we're talking about. And this paradigm for doing it is called Smart on Fire. Both constructs are free. You can go and do this anytime you like. You can work in the vendor sandboxes and build Smart on Fire apps. You might then want to turn around and try and sell them to the vendors. You can. And there is a model to do that, and provided you're not competing with their functionality, then they're happy with that. They've actually supported this, okay? But doing this is free of charge. And I'll give you two little examples here. The one on the left is called Insight, and this is a wound monitoring system, which you can use independently, but you can use anchored within the electronic medical record system. So you take a picture of the wound, as you see on the phone, it sends it to a machine learning algorithm. The machine algorithm, it says something along the lines of this part of the wound is healing, this part of the wound is not healing, this part of the wound is infected, that kind of thing. And then it overlays it back on the wound via augmented reality. So objective, measurable, trackable changes in the wound. And bear in mind, a wound is a 3D construct. It has width and side and depth, okay? You heal up from the bottom of the wound as well. That kind of functionality, those big vendors are never going to build. Never, 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 okay? But allowing others to come in and do this specialist work using these free tools and free paradigms is actually turning out to be quite powerful. The one on the other side is for complex drug prescribing. So some drugs, when we prescribe them, they're the same for everybody. We might change the dose based on a little bit of the specifics of the condition or your weight or your allergies, but it's not too scientific. There are some drugs, however, that are incredibly dangerous, and we need to be very precise with our dosing. Think of the blood thinner warfarin. Many of you may have heard of this drug. We need to give a series of doses to build up the level. We need to check the blood to make sure you're not too thin in your blood, but also still getting thin because we're trying to thin it out. Then we need to ease off the doses because we know if we keep going, it's too high. It's very judgment-based. This tool called Dose, there we go. Forget there's no pointer. Called DoseMe does this for about 40 drugs. So it integrates with the electronic record. It sends the data from the record to a Bayesian-based model, which then recommends the timing and amount of the next dose. So building something like that does not cost, it costs resources, but the tool set and the framework does not cost money. Okay, so again, free of charge to work with. This is an example of evidence around DoseMe, again, because I'm glad I asked about the healthcare audience. This will be over some of your heads, but basically it's talking about a particular nasty drug called vancomycin, which we use in highly complex hospital settings, and it's showing how when the doctors gave the vancomycin traditionally versus giving it under the guidance of the DoseMe model, that they did a lot better job at getting the right level in the bloodstream and keeping it there. The right level to kill the bugs, but importantly, not to do any more harm than they were doing previously. And in particular, no extra harm to the kidneys. This drug can kill the kidneys if you overdose on it. So one of those really complex problems. Again, not the kind of tool set that these companies would traditionally build. Okay, so they're happy to have a third party come in. We've got to test it all, but come in using these free external approaches and deploy in their electronic medical record systems. So a lot in the West, certainly we tend to buy these big commercial systems, but some places don't. And certainly in less developed regions, there's plenty of examples of people working on projects like this. So this is called Open EMR. It's an international collaborative, which basically says all of your healthcare systems may benefit from these electronic medical records, but you cannot afford 60 million Australian dollars, times that by 200 in local currency here, to put the system in, okay? And so a lot of work goes into this, as happens in a lot of open source projects all around the world, okay? Little bit of some screenshots. It's not as whiz-bang and fancy as some of the other systems, but it will do the job, okay? Is it really free? We'll talk about that in a minute. In our case, our federal government has a national health record, which is a sort of a bits and pieces record. It's not intended to be comprehensive. It's intended to be a bit of a sharing vehicle for some of a patient's information. It's called the My Health Record. But they've opened up different kinds of access points, if you like, for people to build products free of charge to then integrate with this national infrastructure. Okay. And of course, you can then sell those or market those if you want. But it's also, I don't see any reason why people around the world cannot access these things, and other governments will be doing this as well. Okay. I spoke before very briefly about how in my world we're covering EMR technologies. They are 50 years old. The first paper I can find about some attempt to go from a paper record to an electronic medical record was published in 1970. 54 years ago. And yet in our country, we still don't have ubiquitous electronic medical records. I know you don't, I know India doesn't, okay. But at the same time, the world's advancing on. I can show you a whole bunch of really cutting edge tools that are in production use that are sold to people now that are at the other end of the spectrum. This is more in this bucket. So this is an open source project called Night Scout, and it's particularly for CGM, continuous glucose monitoring. So the idea is if you have some kind of CGM sensor, which may be the old finger prick and stick in the little device, or it may be the new, we call them Freestyle in Australia, Freestyle Libre, that diabetics wear for continuous monitoring. You can build a project around that. You can build analytics, you can build an app, you can share with people. So this environment, this collaborative is free of charge, okay? I think we will see more of these things. I don't see why we won't. Okay, so we're going to talk about, and I think I'm going pretty good on the old time, not too bad. We're going to talk about analytics and benchmarking a bit more, okay? Anyone heard of OMOP? Observational Medical Outcomes Partnership? Nope, okay. International collaborative, tools, learnings, advice. The idea here is that, let's say, oops, I keep forgetting we can't do that. Let's say we're talking about 3 different medical record systems with slightly different architectures, different owners, whatever, and they may be in, let's say they're in 3 different countries, just to emphasise. What OMOP does is provides you a common data model for you to map your content to, okay? So that everybody's blood pressure readings come down to a commonality, everybody's sugar readings come to a commonality, everybody's problem list comes to a commonality. Because then, of course, if you were in the same place, you can all aggregate your data in one SQL database because you've come to a common data model. Or if you are in 3 different countries, you can compare because you can write some code on the data from source 1 and share it with the people who are holding source 3 because you've stored your data in a common way for analytics, the code will run. So I don't need you to send me your data from Sri Lanka or vice versa. I can say, here's the complex piece of SQL we wrote. Run it on your end and see what you get, okay? So that whole thing is free. Resource intensive, but free. There's no cost to do that, no licensing required. Some OMOP case studies. So again, you're not a medical audience. Our biggest single research repository in medicine, including in health informatics, digital health, is called PubMed, run out of the National Library of Medicine. If you just Google PubMed, you'll find it. These came up just the other day. There's lots of them, lots of places around the world. So we've got Bulgaria, we've got Norway, Catalonia and Spain, all have built different kinds of OMOP aggregations because it's universal, okay, and free. BERT, Business Intelligence Research Tool. I haven't used this one, but I certainly was across it even 20 years ago. So again, open source data warehousing tool, basically, so no cost. There's an overhead, technical overhead, there's infrastructure needed, but the software doesn't cost you any money. We have colleagues in our country in Brisbane who are leading, certainly our country in some parts of the world, around fire. So the JSON data had been made to share in real time, wasn't really made with aggregation and analytics in mind. And there's work going on now to convert it from fire to SQL and other things, but as a waypoint, these people built a free server for aggregating all of that healthcare data in the JSON format and allowing you to write queries, again, free of charge. You just have to install it and host it yourself. And this is more in the benchmarking space and really for people interested in comparing outcomes around the world. So how do I know how prostate cancer treatment in Sri Lanka is going compared to Germany, Australia, India, or the US? You can participate in this kind of thing. It applies across multiple disease states, obviously very common diseases which affect people around the world. And it's already done the work about what are the measures, but it's gone down a few steps and said, well, how do we build into our computer systems the appropriate SNOMED and LOINC codes so that at the other end of the process, it's easy to get comparable data? Okay, so this is called ICHOM, okay? Again, participation is free, lots of learnings and tool sets. And so, for instance, getting these data sets out with all the metadata around it. And just a quick nod to some other things. There's a very famous international initiative called Open EHR, Open EHR, Open Electronic Health Record. They talk about small data. So their approach is to say, let us all try and standardise on the really micro data, and they might use things like SNOMED codes because then it doesn't matter what your computer system does as long as it uses that data. There are a few flaws of that approach, but that it exists. IHE, Integrating the Healthcare Enterprise, deals with that whole idea of we've got 3 different hospitals, how do we get them to share their data and have a common view of it? And again, free tooling, no money to be involved. And I came across a thing called GNU Health recently. It's a whole ecosystem. Not sure how much work they've done, but electronic health records, population health system, personal health records, laboratory information system. But again, free knowledge, free collaboration, free tool sets. Okay. So there's lots of free out there, just this is the open source paradigm, right? Approaches, platforms, tools. Some need technical competency, some don't, so you need to know what you're doing to install a fire server, not so much to play around with ICHOM data. Some need hardware, obviously, for housing development. All need training, effort and labour, so nothing is completely free. There is no such thing as a free lunch, but these things are potentially good for entry level, for researchers and developers and organisations wanting to get into the digital health space. And I'm talking here about building digital health solutions, not just analysing healthcare data, okay, which is much more the domain of our colleagues in epidemiology. Just a very quick shameless promotion. If any of you are interested, we are running a cross-regional health AI event for 2 days in November. You can register via that QR code. We have speakers from India, Vietnam, Indonesia, Malaysia, and ourselves in Melbourne. We would hope maybe next year to have some people from Sri Lanka as well. Very low bar, cost of entry, because we want people to participate, and timed to work as far back as Indian Standard Time. So it'll start early morning in India, early afternoon in Australia. Thank you. I'm not sure if we have time for questions, but I'm happy to take any if we do. Wonderful.
Yeah, one question actually. The information that you have provided actually very new, and thank you for actually conducting that. So my question is like, if a patient, like select a scenario, if a patient admit to the hospital like an emergency response, like from a chest pain. So you have mentioned the data communication method like SNOME and LOINC, like so like to get my better understanding, like is there like the better way? Okay, so as a doctor we should use NOC for like better data transfer, or should we go with the LOINC? So is there differentiation, or do we use FHIR interpretability to in both cases?
Yeah, so assume you have an electronic system. So if you go to the hospital, you have a heart condition, the doctor would use SNOMED in their computer system. So if it was all set up, they might have typically a drop down, and this is in their problem list. They might look at you, decide you have, let's say, angina, which is a heart condition. And they might have a button first that says cardiac conditions. They hit that, and then a drop down will open. It'll have angina, heart failure, ischemic heart disease, myocardial infarction, a selected range of all of the SNOMED codes for them to hit. That's the one. Has to be about that simple, or else they won't do it. Okay. Then behind the scenes, if that patient was actually going to then go to another hospital, to the intensive care unit, because this hospital has emergency but no intensive care, then FHIR would allow that package of information to be sent to the other place. And inside several little packages, several resources about you with your heart condition would be the SNOMED code saying angina, because the doctor selected it at the front end. Does that answer your question?
Yeah. Thank you.
Yeah.
And if you really wanted to, in that second hospital, if they aggregated all the FHIR data, they could store it on a Pathlink server and query it like an old data warehouse.
Yeah, that makes sense. Thank you.
Yeah, I have a question. So nowadays,
Can you pop that microphone nice and high? I'm struggling to hear.
yeah. So nowadays, as AI becomes more integrated into healthcare systems, so what are the consideration, like ethical consideration, do you think are most critical, particularly in EMR or medical record processing?
So if I'm understanding and hearing correctly, as AI becomes more relevant in society, more relevant in healthcare, what are some of the considerations about its use in healthcare?
Yeah.
Yep. Okay. Lots of considerations. It's already in healthcare in different ways. I'll give you a tangible example. So there's this concept now of AI scribes. So there's various companies, some Australian, some not, Heidi, Lyrebird, Meadow. The idea there is if you go and see your practitioner in a clinic, in the family physician's office, they will say, I'm going to record today's consultation on Lyrebird. Do you mind? Assume you say no. They hit the record button, and thereafter the doctor does not need to write any notes or type any notes, because the AI is listening. And then at the end of the consultation, it spits out a little templated summary, and the doctor will check it and go, yeah, that's okay, and import it into their medical record system. That is happening today extensively in Australia and many other countries. The other thing that's already happening today in Australia and many other countries is in radiology systems. So the X-ray people, they're already examining lots of X-rays, chest X-rays, CT scans of the brains, using AI, and the AI system will preemptively say, these are all the things I can find and then the doctor will check and say, I agree, or I must check that one, or whatever. So that sort of stuff's quite ubiquitous. The considerations are multiple. Who pays for it? Do we have a social licence to do it? Has the patient been made aware and do they agree? What happens when LLMs hallucinate, etc., etc., and it goes on and on and on. Is somebody attacking our system? Can we trust it? There's a paper out of Israel from 5 years ago done in a research setting about, it wasn't about AI so much, they used the GAN, but they deliberately intercepted the messages which are called DICOM messages, describing a CT scan moving around inside the hospital network. Where the CT scans had lung cancer, they deleted the lung cancer. And when the CT scan had no lung cancer, they inserted a lung cancer. And they were able to fool the radiologists. Okay. So many considerations. Personally, our healthcare systems are too stressed. They cannot cope. All around the world, we need help. AI will help. We just need to be very careful with it. So I hope that answers your question.
So I have a question. So my question is usually whenever the previous question was that the person come to the hospital,
Yes.
then the process begins. So if we can make a solution that imagine I have a chest pain at the home. So
Yes.
if we can get the data from that point onward, then can we implement that kind of solution using the same technologies that you mentioned during the presentation?
So are you talking about a system that preemptively collects the information, sends it ahead of time to the hospital because you're going to get there?
Yeah.
And you just, okay. People have tried this kind of thing. Could you, with this, you do, but you might need some kind of AI intermediary to synthesize what you put in. But the short answer is yes. Things like SNOMED, for instance, and LOINC and that kind of stuff should be used in such a system, or else it's not very sustainable. How do you define the different conditions or the different systems if you don't have a master index from which to pull? So they would fit into such a thing. People have tried this. I've not heard of it happening successfully yet, because it's one of our complexities about we see lots of points in healthcare where we think it might help and then we find it doesn't. But it doesn't say don't try.
So I have a question.
Sorry? Oh, there we go. Thank you.
What are the main limitations for these free digital health tools?
Yes.
And also, how these digital health tools user-friendly for all the adults or the limited digital literacy people?
So the first bit was about what are some of the limitations of the tools, and the second is
how user-friendly?
how user-friendly. Sure, okay. Well, the biggest limitations to start with, there's still a technical overhead. It's not magic. It's not insert a CD, tick yes, because you're setting up free infrastructures. So some of that stuff you absolutely need to have either be a technical person or have a technical person in your team. But the big thing is licensing. You're saving a huge amount of money on licensing. You also get a freedom with some of this stuff to extend it, right? To tinker with it, to take it to the next level, which you might do in collaboration with someone in another country, whereas vendors don't want you doing that. So biggest consideration usually is, do I have the technical nous and ability to host these things in the first place? Because sometimes it's beyond, will it load on my machine? You know, you're just going to run out of space. Often, I guess the general thing I'll say is often those bigger things, especially stuff like SNOMED and LOINC, OpenEMR, that kind of stuff, there's whole communities. They don't exist without those communities. So there's enormous numbers of people. Same with FHIR, you can call on around the world. There's listservs, there's help groups, there's conferences. And that might frame your selection of a tool. You might have several competing tools, but This one might be newer and look sexy, but this one's been around for 20 years and there's thousands of people around the world you can work with on it. That's an important consideration. So I hope that helps.
So I have one problem.
Are we allowed to keep going or do we need to stop for lunch?
Yeah. So, these days, data privacy becoming one of the major problem, and
Sorry, I'm really struggling to hear
yeah,
you.
data privacy becoming one of the main problem. And I wanted to know how can digital health solutions can maintain transparency and trust with the users.
Yeah, that's a very broad question. I mean, these things aren't immune from bugs. They're not immune from being hacked. So all the sort of usual risks to data privacy, you can implement them poorly and sacrifice privacy and confidentiality. All those things still apply. There's no magic solution to those issues. Okay. You know, and sometimes maybe that's an extra cost. Maybe you employ a consultant to build you your local open EMR instance because they're familiar with that stuff. You've got to pay the consultant, but you still don't have to pay $60 million to a big company. Okay. I view the issues of transparency as a little bit agnostic to the technology I've shown you. They're important issues, but is there anything special about these technologies versus commercial technologies with that question in mind? I'd argue there's not. It's a bit of a non-answer, but that's my gut feeling.
Sir, I have a question. Here. Okay, so you talked about this IR architecture. So there are lots of legacy systems and documentation, like manual documentation. So are there like documentation that non-technical people can easily use to convert these legacy systems or documentation into this IFR architecture? Because it will be easier. So about that.
So you're talking about using FHIR to connect up legacy systems, and is there documentation around to help you do that? Well, the trouble with that is that the legacy FHIR will help you, but the legacy systems at each end have to sort of speak FHIR. So if you've got a SQL database there on an operational application, that's not native FHIR. However, there is work going on, as I said before, about translation between FHIR and SQL, usually in that direction though. So the challenge there is not the FHIR bit, it's how is the data in a traditional SQL format going to get in FHIR so maybe it can be shared to the other operational old system. Does that answer your question? I'm confident there's enough documentation out there to anyone interested in working with FHIR. I have zero doubt. I've seen it, I've used it, I've pointed my programmer to it. There's increasing amounts of training. HL7, the HL7 organisation, which has an international presence, is not a bad starting point if you want to learn about doing FHIR. They have introductory courses. You can step up your levels of accreditation with them. So it's nowhere near a whole university degree commitment, for instance. You can do it while you're working, while you're studying other things. That will cost you money though, because they do charge. Yeah.
Thank you, Professor Bain, for the insightful session in what in digital health is free. It helped us see the hidden costs and challenges behind the free digital health tools, especially around data privacy and access. Dear sir, please remain on stage to receive a small token of appreciation. We would now like to invite Professor Kasun D'Souza to come forward and present a token of appreciation to Professor Chris Bain. Thank you, professors.